Thank you very much, everyone. Good afternoon, Mrs. Harris, ladies and gentlemen. It is with great respect and a tremendous honor to be invited to give the Professor Edward D. Harris Jr. lecture today and to comment on MSK education, the past 10 years, and the ongoing challenges for the next decade. The focus of this presentation will be to provide an overview on educational research and strategies initiated over the past decade to enhance education pertaining specifically to MSK health and related conditions, such as learning styles, methods of delivering curricula, evaluation strategies focused on educational experiences, assessment tools to determine clinical competencies, interprofessional education, and the implementation of team care models, and finally, transfer of knowledge to optimize patient care. It is really hard to believe that 10 years have passed and the bone and joint decade is coming to an end. As we all are aware, the main goal of the BJD was to improve the quality of life for people with musculoskeletal disorders worldwide, with one of the main focus to increase training and education of healthcare providers at all levels. Over the past 10 years, MSK educational research, along with education of healthcare providers, has certainly undergone an extensive review. Globally, tremendous effort was directed towards the validation and development of curriculum competencies for potential implementation into academia. Understanding how individuals learn may assist in optimizing an individual's educational experiences. Learning styles may be defined as the intuitive mode of perception, processing, storage, and recall of information that is learned, spontaneously demonstrated by a learner without conscious awareness in a variety of situations with similar requirements. The benefits of teaching to an individual's learning styles may include the ability for educators to establish an open dialogue with their students, thus enhancing the learning environment to be more interactive and efficient, resulting in a more rewarding and satisfactory educational experience for both the teachers and the learners. Finally, by catering to the needs of a potentially diverse population, teachers promote education for the typical and atypical students that may be sustainable for a diverse educational system which we are all striving to attain. Believe it or not, no studies have been completed to identify the specific learning styles of orthopedic surgeons. Several instruments exist to assess learning styles, and for the purpose of this study, we elected the Kolb Learning Style Inventory since we predicted a higher response rate with orthopedic surgeons using an instrument that only had 12 questions versus other instruments that had over 150 items. The Kolb Learning Style Inventory was created in 1970 by David Kolb, a PhD student studying psychology of learning while at Harvard University. This theory is based on experiential learning theory that identifies learning as a two-step process involving both information perception and information processing, whereby learning by experience accentuates active learning. A study was undertaken to determine learning styles of an orthopedic residents and their faculty educators at one orthopedic accredited institution within Canada. A cross-sectional survey using the Kolb Learning Style Inventory was completed with 60 orthopedic residents and their 60 faculty members at one institution. Direct one-to-one interviews were completed with the primary investigator and each participant using the Kolb Learning Style Inventory. Scores were computed to determine learning styles and associated learning steps for both residents and faculty members. A specific scoring system is completed to identify the preferred learning style to be one of 4 possible categories. Information perception continuum, which consists of learning by experience and thinking, versus the second continuum that consists of the act of doing and reflecting. This will then allow the participants to have their preferred learning style to fall in one of the 4 categories, either diverging, assimilating, converging, or accommodating. The results of this study are as follows. 60 of the 60 residents participated for a 100% response rate. The converging learning style was the most common learning style among the residents, followed by assimilating, accommodating, and diverging. Similarly, the faculty demonstrated a similar trend, with converging being the most prominent, followed by assimilating, diverging, and accommodating. The implications of this research may be beneficial with the emergence of competency-based education. Would learning be enhanced if education was specific to an individual's learning style? If both residents and faculty became more aware of their own learning style, then one may potentially understand how to optimize learning from a designed program, how to problem solve, how to work cooperatively within teams, how to manage conflicts, and how to optimize professional and other relationships. Converging learning style preference, whereby learning occurs predominantly by actively solving problems, was most common for both our residents and our faculty. The main characteristics associated with this style are the ability to solve problems, make decisions, reason deductively, define problems, and being logical. It is important to note, however, that the faculty participants had a learning style that could have been one of converging or assimilating. It was quite close. We know that learning anything new can be difficult, so how can this study be made generalizable to the real world? Is the converging learning style applicable to most residents in surgery, or is it unique to orthopedics? How do teaching styles of faculty impact the learning styles of any resident? And how can we better understand if teaching to learning styles actually makes a difference? This leads us to the topics of what competencies are required for certification of anything, what educational environments will lead a learner to become competent, and how do we determine competency of anything? Over the past decade, a focus was on students that in all medical schools should know MSK health and related conditions, known as the competencies. 92 core competencies for MSK health were determined in Canada based on the initial work completed by the World Health Organization Bone and Joint Decade Undergraduate Curriculum Group, spearheaded by Professor Wolf. The study was then expanded to determine core competencies for orthopedic surgeons. From this study, 240 competencies out of a potential 281 competencies were identified by a random sample of orthopedic surgeons from across Canada whose primary affiliation was non-academic to be important for any orthopedic surgery graduating from a residency program in Canada. There was an 84% response rate, and this, I believe, reflects the importance of the topic. The results of this research were then put into direct use. The Royal College of Physicians and Surgeons of Canada Specialty Committee for Orthopedic Surgery incorporated this data into the rotation-specific objectives in CanMed's format during 2 working group sessions in 2007. In addition, educators from various countries around the globe have requested directly the competencies so they can apply them to their respective programs. And finally, within the Division of Orthopedics at one of the universities within Canada, a procedure logbook based on this data is currently undergoing review and study. Educators may wish to consider the mechanism by which learners will achieve competencies and how to enhance the educational experiences for their learners to become competent. An interactive workshop was developed and a summary of proceedings for orthopedic residents on strategies to improve knowledge and skill acquisition was completed. A needs assessment was completed by current orthopedic residents. The residents indicated that they really wanted to learn how to set their educational environments and how to prepare for a specific rotation, how to identify the learning opportunities that present to themselves, and how to make learning really stick. And finally, how to prepare for the milestones and the rate-limiting steps from progressing to the next level of training. Specific workshop templates were created based on this feedback. These were constructed to identify content and facilitate discussion relevant to these domains. 44 orthopedic residents ranging from PGY1 through to PGY4 were invited to attend the workshop. They were pre-assigned based on random assignment of residents listed by years. The PGY5 residents were excluded because of exam conflicts. However, 2 of the successful PGY5 residents that just completed their examinations acted as facilitators for the plenary sessions. A workshop schedule outlining each of the small group discussions was constructed, and there were 3 major themes and 5 groups. After each major theme, a plenary session was held for full group participation and feedback. The results indicated 44 out of 48 residents participated, and a summary of the proceedings was generated. 3 main themes emerged from the workshop discussions to be of critical importance to residents. This included their interactions with others, and these can be any others that are in their educational environment. Second, resources made available to them both clinically and academically. And third, how they manage their time. These same themes may also be applicable to any learner of any discipline, of any profession, and not limited to orthopedic surgery. So this workshop, as a template, can be transferable to other domains. One of the most important principles to consider in education is how to evaluate competencies. The following list of outcome measures outlines some mechanism by which competency can be assessed. The problem is that in order to truly, effectively assess these measures, each must undergo testing for validity, including the process that will determine face, content, construct, and criterion-based validity. This can be very difficult to do and would require funding to run the necessary studies to validate each of the learning and assessment tools. If we are able to demonstrate that educating healthcare providers and patients is economically cost-effective in terms of enhancing individuals' potential years of life while decreasing healthcare expenditure, then it may be possible to see educational activities receive priority funding. Having said all this, the true test of any clinician's competency may also be seen in how patients are managed and the outcomes generated. Good clinical outcomes based on relative comorbidities that a patient possesses may suggest a competent clinician. The problem with this method is that it may take years to determine true competency, and also over time, competency may change for various reasons. So determining competency of anything at any level can be extremely difficult. This is why research is being done to assess the transfer of knowledge towards patient care and outcomes, with patient safety at the forefront of everything that we do. Can competency be assessed by using patient simulation that provide learners with lifelike opportunities to practice real scenarios? Can it be done via cadaveric lab simulators, where learners experience real-life interventional procedures without putting a patient at risk, and may be especially useful for difficult surgical procedures often performed in various surgical disciplines managing patients with MSK conditions? Can competency be assessed by means of online simulation? The ability to screen, identify, and initially manage patients with inflammatory arthritis was identified to be a priority item in the 2005 National Summit on Standards for Arthritis Prevention and Care. The purpose of this project was to determine the contents, its accompanying assessment tools proposed for an interactive technology learning resource pertaining to rheumatoid arthritis. A project team consisted of both content expert team, as selected by the Canadian College of Family Physicians and the Royal College of Physicians and Surgeons of Canada, with quality assured experts along with a patient representative and a resident learner. The design team consists of technology, methodology, statistical, and communication experts to support this content team. The focus is on MSK condition we are trying to identify, and in this case, it was the ability to screen for arthritis, identify inflammatory arthritis, and educate providers regarding referral to subspecialty care. Subject matter experts were recommended by the professional associations to develop content for the gait, arms, legs, spine screening exams for arthritis, and a sore hand, sore feet case simulation. Evaluation templates were developed, a storyboard with instructional designers for interactive educational experience and assessment tool was completed, and a technology template was constructed. 80 Canadian healthcare providers were invited to review this online content, and each participant was provided access to the MSK website for the learning modules. 62% of the invitees participated in this study. There was a statistical significant increase in scores from pre to post-test measures, with a p-value of less than 0.001 for the GALs and also for the sore hands, sore feet module, with a pre-post differential being significant at the p minus less than 0.01, excuse me. The GALS and sore hands, sore feet evaluations demonstrated questions that provided good discriminators among all respondents. This research was accepted recently as a podium presentation for the upcoming American Academy of Orthopedic Surgeons annual meeting in February of 2011.